This is the study guide to review for assessment number 3, which covers GI, endocrine, and neuro medications. So the material is organized by body system rather than the order that I posted it on Brightspace. So we'll cover GI first, and then endocrine, and then neuro, and then finish with dosage calculation. So assessment number 3 covers 3 medication units plus dosage calculation. GI covers antacids, acid suppression, ulcer treatment, bowel management, antiemetics, and chronic bowel disease. Endocrine covers thyroid replacement, antithyroid hormone, glucocorticoids, insulin, metformin, and desmopressin. And then neuro covers seizure medications, Parkinson's medications, migraine, glaucoma, and sedation. And you will see also weight-based dosage calculation. So for every medication in this review, just be able to state these 4 things: what it treats, how you know it's working, what you teach the patient, and then which adverse effects you require follow-up. So the first one that we will cover is GI pharmacology, and it's the largest section. So for each medication in this unit, you know what it does to the bowel pattern and which patient should not receive it. Renal patients come up repeatedly. There are 3 antacid bases, and each one behaves differently. So aluminum hydroxide, the brand name is Amphogel. It causes constipation. So we teach to increase fiber and fluids and anticipate that a stool softener may be needed. Aluminum hydroxide also binds phosphate. That is why it is the antacid of choice for renal failure patients with elevated phosphorus. Dialysis patients take it with meals as a phosphate binder because the kidneys can no longer clear phosphorus. The same property means you would question an order of aluminum hydroxide in a patient whose phosphorus is already low. Calcium carbonate, which is Tums, is usually given with meals when acid secretions are peaked. So we do not crush the tablet, and we do not administer it with milk. We separate Tums or calcium carbonate from any iron supplements because calcium interferes with iron absorption. And then magnesium-based antacids, such as milk of magnesia, these cause diarrhea. So avoid them in renal patients because failing kidneys cannot clear magnesium. So for a renal patient asking which over-the-counter antacid is safe, the answer is aluminum-based. Calcium and magnesium both accumulate when kidney function decline. So both of these medication classes reduce stomach acid, but they are taught differently. So H2 blockers include ranitidine, and that brand name is Zantac, or cimetidine. Now, in male patients, we want to make sure that we are teaching about impotence and gynecomastia, because if patients don't know that this is going to happen as a result of this medication, then they will stop taking this medication on their own. So we make sure we provide that education. But cimetidine can also cause dysrhythmias, so palpitations are associated with that medication specifically, with cimetidine specifically. Proton pump inhibitors include omeprazole, and that brand name is Prilosec. So there are 2 administration points that matter. So this medication needs to be given on an empty stomach on a schedule, and it's not given as needed for heartburn. So we do not crush, chew, or open the capsules of this medication. Now, the empty stomach requirement exists because the medication must be absorbed and bound to proton pump before the first meal triggers acid release. So the standard instruction is 30 to 60 minutes before the first meal of the day, taken regardless of if symptoms are occurring right now or not. The capsules are formulated to survive stomach acid and release further down the GI tract, so crushing or opening the medication destroys it altogether. Now, a proton pump inhibitor is working when dyspepsia decreases, and that just means indigestion. So we know that a proton pump inhibitor is working when indigestion decreases, and that's what dyspepsia means. Now, headache, nausea, and diarrhea are side effects of omeprazole, not indicators of therapeutic effect. Misoprostol, the brand name is Cytotec, is a synthetic prostaglandin. It replaces the protective prostaglandins that NSAIDs remove from the gastric lining. So it is used to prevent and treat NSAID-induced gastric ulcers. So associated with long-term NSAID use and new peptic ulcer disease. Now, misoprostol causes uterine contractions, so it is 100% contraindicated in pregnant patients. Now, for H. pylori with peptic ulcer disease, treatment is a combination regimen of antibiotics plus a proton pump inhibitor. So discharge teaching is to take the full combination for 14 days as directed. Now, compliance is usually the issue. Patients often feel better within 3 or 4 days and they stop taking the medication early. If the regimen is not completed, the bacteria survive and the ulcers continue to recur. Now, 2 points on discharge teaching. For smoking, of course, the goal is cessation, not reduction. For NSAIDs, the teaching is to avoid them and consult the provider rather than a blanket instruction to just never use them again. So, with misoprostol or Cytotec, we are teaching smoking cessation. We're not saying, cut back on your smoking. We're saying stop altogether. And then for NSAIDs, we are teaching them to avoid them and consult their provider versus just that blanket instruction to never use them again. Elevating the head of the bed addresses reflux, not peptic ulcer disease. So with constipation versus diarrhea drugs, you want to know which ones treat constipation and which ones treat diarrhea. So Psyllium, which the brand name is Metamucil, is a bulk-forming laxative. It absorbs water and increases the size of the fecal mass. So the primary teaching point is adequate fluid intake because without enough water, the product solidifies in the GI tract. Also, the onset of this medication is between 10 to 24 hours. Now, because psyllium treats constipation, an order for psyllium in a patient with diarrhea is absolutely an order that you would question. Docusate, which the brand name is Colase, is a stool softener and is appropriate in diverticulosis. Bisacodyl, brand name Docalax, is a stimulant laxative. So for diarrhea, diphenoxylate with atropine is called Lamodal, and loperamide, which is Imodium, are the 2 medications to know. So one principle applies broadly. If the appropriate intervention is already ordered as a PRN medication, administer it. Calling the provider, increasing an IV rate, or obtaining a specimen, those all require orders that you may not already have. So if you see a question and it says something like, your patient is experiencing episodes of loose, watery stool, and you look at their medication record and maybe they have Tylenol ordered and PRN, and they have like a PRN nausea medication ordered, and then you see that they already have Lamodal or loperamide ordered, give it, right? It's already on their medication record because it is known that this patient is having watery stools. So there is nothing further for you to do. We would not send a stool sample because that's exactly why the patient is there, for something that's causing them to have loose watery stools. So we don't need another stool sample. We would not need to contact the physician because the patient already has this diagnosis. The physician is already aware that the patient is having loose watery stools. So at this point, there is no need to contact the physician. And doing something like increasing IV rate, why would we do that if we haven't been giving any indication that maybe this patient is dehydrated? So the patient having an episode or 2 of like loose watery stool is not an immediate concern for dehydration. We always look out for the signs and symptoms, but we do what's already there in front of us. So if a medication is already ordered on the medication record, then give it. Sorry, went on a little bit of a tangent there. So with ongoing diarrhea, we do monitor potassium and maintain fluid intake. Now that's with ongoing. If it just says 1 to 2 episodes, that's not considered ongoing. So potassium is lost with every liquid stool. So that's why we continue to monitor the potassium and maintain fluid intake. Okay, so next we're going to discuss these three antiemetics. So ondansetron, Sofran, is a serotonin 5-HT3 blocker, and it's used for nausea and vomiting that's related to chemotherapy, radiation, and surgery. And its most common adverse effect is headache. We also monitor for urinary retention. Metoclopramide, which is also called Reglan, relieves nausea by promoting gastric emptying and increasing gastric muscle contraction. So when we are explaining it to a patient, we explain it just like that. It does not relax the stomach and it does not slow peristalsis. Metoclopramide is generally avoided in children because of the extrapyramidal symptoms. These are considerably more likely in the younger population, so we do use ondansetron. And then promethazine, which is also called Phenergan, is a sedating PRN antiemetic. It treats nausea, not diarrhea. So these two medications really are testing whether you can evaluate therapeutic effect. So allosetron, the brand name is Latronex. It treats diarrhea predominant irritable bowel syndrome, and it is effective when pain and diarrhea decrease. So how do you know this medication is working? The pain decreases, the diarrhea decreases. So sulfasalazine, and the brand name is azulfonide, it treats ulcerative colitis. It is effective when diarrhea and abdominal pain decrease. Now, in both cases, constipation indicates overshoot, not therapeutic success. Bloody stools indicate a complication, not improvement. And also, the allosetron carries a black box warning for ischemic colitis. It is restricted to women with severe diarrhea predominant irritable bowel syndrome who have not responded to other therapy. Any bloody stool means the medication is stopped and the provider is notified. So the next unit are the endocrine medications, and most of this unit follows from knowing what the hormone does. So too much thyroid hormone produces hyperthyroid signs, too little produces hypothyroid signs. Glucocorticoids raise blood glucose, so insulin requirements increase. So levothyroxine is the thyroid hormone replacement. An excessive dose produces hyperthyroid signs, insomnia, restlessness, tachycardia, palpitations, hyperthermia, nervousness, and weight loss. An inadequate dose leaves the patient with hypothyroid symptoms, constipation, drowsiness, and hypoactive reflexes. These indicate the dose is too low, not that the patient is toxic. That distinction is where students often lose out on points by selecting the incorrect answer. So when a patient is receiving an inadequate dose of the levothyroxine, the patient will experience those hypothyroid symptoms. So the finding that requires notifying the prescriber are the cardiac ones: tachycardia, palpitations, and chest pain. In an older adult with an underlying coronary disease, excess thyroid hormone can precipitate angina, which is why therapy is always started at a low dose and then titrated slowly. So we are monitoring by assessing their serum TSH and free T4 levels. BUN, complete blood count, and serum iodine are not used to monitor thyroid replacement. I am not even going to try to pronounce this medication because I don't feel like stuttering through this slide. So we are just going to call it PTU. And it's an antithyroid medication that lowers thyroid hormone levels. It is used to prepare a patient with Graves' disease for subtotal thyroidectomy. Graves patients with tachycardia, heat intolerance, and the exothalamus So hormone levels must be reduced before surgery. So distinguish the medication classes. So propranolol controls the cardiovascular system, but does not affect hormone production. Levothyroxine and liothyronine are replacement hormones and would worsen the condition. Patients taking PTU should avoid foods that are high in iodine, including iodized salt, seafood, and soy products. Iodine is the raw material for thyroid hormone synthesis. So one assessment scenario to know: a patient being treated for hypothyroidism who develops insomnia, nervousness, and flushed skin has become hyperthyroid, which can progress to thyroid crisis. You assess the heart rate for tachycardia before notifying the provider. So that just means you gather all of your data first. So we do know in this instance that we would contact the provider, but first you do an assessment, right? Because you have to know what else to report to the patient. So when you do notice that this is happening, your patient with hypothyroidism start to develop insomnia, nervousness, and flushed skin, that just means that they're now leaning toward a thyroid crisis. We assess their heart rate for tachycardia, and then we notify the physician. There are two concepts with glucocorticoids. First is the tapering. So while the patient is taking an exogenous steroid, the adrenal gland stops producing cortisol. If the medication is stopped abruptly, the patient has no cortisol available. That is adrenocortical insufficiency, which presents with profound weakness and hypotension and can progress to adrenal crisis. So tapering allows the adrenal function to recover. Acromegaly involves growth hormone. Hypertensive crisis and thyroid storm involve thyroid medications. So those are separate hormone systems. So second is blood glucose. Glucocorticoids cause hyperglycemia. An insulin-dependent patient who starts a glucocorticoid requires an increase in their insulin dose. So the steroid dose is not adjusted because it is treating the underlying condition, and decreasing insulin would worsen the hyperglycemia. So there are 4 rules for insulin. First is mixing regular and NPH in one syringe. You inject air into the NPH vial first, then draw up the regular insulin, which is clear, followed by the NPH, which is cloudy. So clear before cloudy. Second, the NPH time course. Onset is 1 to 2 hours, peak is 6 to 14 hours, and duration is 16 to 24 hours. The risk for hypoglycemia is highest at peak. A patient who takes NPH at 7 in the morning is at greatest risk in the early to mid-afternoon. The third rule is appearance. NPH is normally cloudy. You roll the vial gently between the palms to mix it. You do not shake it because air bubbles produce an inaccurate dose. Regular insulin must be clear. If regular insulin appears cloudy, discard it. And then the fourth rule is storage. Unopened vials are refrigerated. Insulin is never frozen. Freezing actually destroys it. So metformin extended release is used in type 2 diabetes. So it is taken with meals. This reduces GI upset and improves absorption. Extended release tablets are never crushed or chewed because that releases the full dose at once and can cause hypoglycemia. Metformin does not change urine color. Sweating is not a direct medication effect. It is a warning sign of hypoglycemia and should be taught to the patient. Desmopressin, or DDAVP, is a synthetic antidiuretic hormone. It is used in diabetes insipidus and can cause the kidneys to retain water. We monitor urine output, which should decrease with and serum sodium because retained water dilutes sodium, and hyponatremia is a significant complication. So I feel like I should say that again. We monitor urine output. So when your patient is taking desmopressin or DDAVP, we are monitoring urine output, which should decrease, and serum sodium, because retained water dilutes sodium and hyponatremia is the significant complication. So desmopressin is working when thirst decreases and urination decreases. Okay, so the last unit is neuro medications. Seizure medications make up a large portion. So there are three themes that run through: recognizing toxicity, teaching that therapy is lifelong, and identifying which symptoms require immediate action. Phenytoin has a narrow therapeutic range, 10 to 20 micrograms per milliliter. So a level above 20 is toxic and needs to be reported to the provider immediately. So as the levels rise, you can expect to see nystagmus, which is that uncontrolled movement of the eyes, ataxia, which is the loss of the muscle tone, and slurred speech. Constipation, weakness, and insomnia are not emergencies. A toxic level is an emergency. So seizure therapy is typically lifelong, and we do educate patients that the therapy is lifelong. So a patient who says something like they're looking forward to stopping this medication, or they're looking forward to when they don't have to take this medication anymore, they do need further teaching, because abrupt discontinuation of this medication can precipitate status epilepticus, which is also an emergency. Alcohol increases the risk of phenytoin toxicity, so we make sure to teach this directly. Phenytoin causes gingival hyperplasia, so we are teaching our patients about meticulous oral hygiene, brushing, flossing, and regular dental appointments. We do not administer antacids with the dose because they reduce absorption. The patient should check with the provider before starting any new medications when they are also taking phenytoin or Dilantin. So the patient needs to be taught to take the dose at the same time each day to maintain a steady serum level. So carbamazepine, the brand name is Tegretol, can cause bone marrow suppression, including leukopenia, anemia, and thrombocytopenia. So new unexplained bruising is the finding that takes priority. It suggests declining platelet production. So bruising, bleeding, sore throat, and fever all point to falling blood counts. Fatigue, nausea, and dry mouth are common and manageable. Marrow suppression is not. Patients on carbamazepine receive periodic complete blood cell counts for this reason. Now, valproic acid, also called Depakote, requires monitoring for suicidal ideations. This is an FDA class warning that applies to anti-epileptic medications in general. So we ask about moods directly at follow-up visits, particularly early in the therapy. And then valproic acid causes weight gain and increased appetite, not weight loss, and it does not cause hypertension. Levodopa with carbidopa together, that brand name is called Sinemet, and it's the medication to treat a new diagnosis of Parkinson's disease. So it replaces the dopamine lost because of Parkinson's. So the carbidopa component prevents the peripheral breakdown so that more levodopa is able to reach the brain. Selegiline is an MAO-B inhibitor. So patients taking it must avoid trimine-rich foods because the combination can cause a hypertensive crisis. So tyramine-rich foods includes aged cheese, cured meat, red wine, and fermented products. So fresh foods, including fresh fish, poultry, and fruit are acceptable. The rule is that aged, cured, or fermented foods are restricted. Fresh foods are not. Sumatriptan, the brand name is Imitrex, is used for migraine. Swelling of the eyelids and lips is reported immediately. that presentation is angioedema, and it can progress to airway obstruction. So remember that angioedema is always an emergency. Angioedema is considered an airway emergency. So anytime we notice that our patient's lips are swelling, we want to report that immediately because it can rapidly progress to airway obstruction. Now, sumatriptan is abortive. It's not preventative. So it is taken at the onset of a migraine. It's not taken daily. Tablets are swallowed whole, and repeat dosing follows the prescriber's instructions. Now, timolol is a beta blocker that's used for glaucoma. And remember the LOL medications, right? Those are the beta blockers. So timolol is a beta blocker used for glaucoma. It is taken on a regular schedule for the rest of the patient's life. It is not used as needed for eye discomfort, and it is not discontinued once intraocular pressure normalizes. Glaucoma is asymptomatic while it damages vision. So patients need to understand that it is going to be an ongoing maintenance therapy. So for administration, we instill the prescribed number of drops into the conjunctival sac, formed by pulling down the lower eyelid. So keep the dropper tip sterile. And then you apply gentle pressure to the inner canthus to limit systemic absorption through the tear duct. So midazolam, the brand name is Versed, is used for moderate sedation. It produces sedation and amnesia. So when a patient expresses fear about a procedure, an accurate response is that the medication helps ease discomfort and that most patients have no recollection of the procedure after. Do not make absolute promises about what the patient will or will not feel. Diazepam, the brand name is Valium, and benzodiazepines are generally depressing to the central nervous system. So the priority nursing action is monitoring respiratory status, particularly with IV administration and when combined with opioids. So for a patient recovering from general anesthesia, the immediate concern is airway. So airway precedes reflexes, sensation, and level of consciousness. So the highest anesthesia risk is associated with advanced age combined with major surgery. Okay, so just to do some dosage calculation, with weight-based dosing and IV push dosing or calculations, they both use the same desired over have. You don't have to come up with a new formula to use. We can continue to use our desired over have times the vehicle or the volume to solve these problems. So our first practice is with cephalexin, 30 milligrams per kilogram per day every 6 hours for a patient who weighs 66 pounds. And what we have available is a suspension of 250 milligrams in 5 milliliters. So the first thing that we do is we convert our pounds to kilograms. So 66 divided by 2.2 gives us 30. So then we determine our daily dose. We take that 30 milligrams, we times it by the 30 kilograms, and that gives us 900 milligrams per day. But this medication is ordered every 6 hours. That means they are going to receive 4 doses in a 24-hour period. So we take that 900, we divide it by 4, and that's going to give us 225 milligrams per dose. So what we have available is 250 milligrams per 5 milliliters. So we take our desired 225, we divide that by what we have, 250, times that 5 milliliters, and that's going to give us 4.5 milliliters. Now, when we are doing our practice IV push calculation, we use the same desired over have formula. So what is ordered is 3 milligrams, and what we have available is 5 milligrams in a 1 milliliter vial. So we take what we desire, 3 milligrams, we divide that by what we have, 5 milligrams, times 1, which is the 1 milliliter that it's in, and that's going to give us 0.6 milliliters. Now, you can do a sanity check here. The order is less than what's in 1 milliliter, so the answer must be under 1 milliliter, and that's your sanity check. So 5 things just to kind of memorize. One, a medication is effective when the symptoms it targets decreases. Effectiveness is not indicated by a side effect, and it is never indicated by bleeding. 2, priority goes to airway, breathing, and signs of toxicity before comfort complaints. 3, when a question asks which statement indicates a need for further teaching, look for the statement about discontinuing a lifelong medication. 4, for renal patients, aluminum-based antacids are appropriate. Magnesium and calcium are not. And then 5, for weight-based calculations, convert to kilograms first, then divide the daily dose into individual doses.